Hello and welcome to today's webinar, hosted and produced by EMG and sponsored by a grant from GE Healthcare. The views and opinions may not be those of either EMG or GE. I'm Dr. Jonathan Sackier, a simple surgeon by background, and I serve as chairman of the EMG Medical Advisory Board. I'm delighted to be chairing the educational activity because this topic is so very important. Today, we'll be covering the subject of acute kidney injury in complex, high-risk interventional catheter lab procedures. I'm delighted to tell you that we are joined by an esteemed faculty today. The agenda for this webinar will start with Dr. McCullough, who'll be covering why acute kidney injury, or AKI, and contrast-induced AKI, or CI-AKI, and sometimes also referred to as CA-AKI, contrast-associated acute kidney injury, why it's important in interventional cardiology, specifically in the cath lab setting. This will be followed by Professor Brilakis, who will be covering the risk of AKI or CI-AKI in the cath lab and several risk mitigation strategies. Following this, I shall chair a panel discussion and then a question and answer session with you, the audience. Please submit questions throughout via the question box that you can see on the bottom of your screen. And you can submit them throughout the event, and we'll endeavor to answer as many as possible at the end. Firstly, please welcome Dr. Peter McCullough, a practicing internist, cardiologist, and epidemiologist from Dallas, Texas, in the United States. Dr. McCullough is a founder and the current president of the Cardiorenal Society of America, an organization dedicated to bring cardiologists and nephrologists together to work on the emerging problem of cardiorenal syndromes. His resume is impressive, with numerous publications, and he's the editor-in-chief of Cardiorenal Medicine, Reviews in Cardiovascular Medicine, and senior associate editor of the American Journal of Cardiology. He also serves on the editorial boards of multiple specialty journals. Peter's also served as a member or chair of data safety monitoring boards of 24 randomized clinical control trials. Welcome, Dr. McCullough.
I'm Dr. Peter McCullough, and it's my pleasure to present today why is acute kidney injury and contrast-induced acute kidney injury important in interventional cardiology. And what I will do is I will make a few points with respect to each of the bullets in this outline. And the first deals with the etiology of acute kidney injury, or AKI. What do we know here? We know that in the setting of the most important emergency in interventional cardiology with acute myocardial infarction, that the acute myocardial infarction itself can be associated with acute kidney injury, even without heart catheterization or exposure of contrast. Clearly, the exposure of contrast is both chemotoxic and vasoconstrictive to the kidneys. And then lastly, we believe there's a contribution of atheromicroembolism. This occurs with larger catheters, certainly from the femoral approach, to lesser degree with radial artery catheterization and smaller catheters. Hard to quantitate, but in the literature, a contribution of atheromembolism is always there. A signal in the data. In patients who present with acute myocardial infarction, there's clinical factors such as an inadequate time for prophylaxis, can be hemodynamic instability, which can be transient or sustained. And we use higher contrast volumes in the setting of primary angioplasty, largely because of testing, our stenting, and then our assessment of the other non-infarct related vessels. Even if we skip the left ventriculogram, we ended up with higher contrast volumes. We know there's biologic factors, including neurohormonal abnormalities and surges that are related to acute kidney injury. There's decreased renal blood flow. That's been shown in multiple studies. Release of labile iron. A lot of cardiologists don't think about this, but myoglobin is rich in iron, and when it's released, it is nephrotoxic. There's this contribution of atheromembolism I mentioned. And as shown here, there's stasis of contrast in the peritubular network. Contrast is very water soluble. And so once it gets out of the blood into the urinary space, and then from the urinary space into the perinephric plexus of vessels, it can be sustained there. And that's what creates the persistent nephrogram that cardiologists are so aware of. This review in the New England Journal of Medicine a few years ago was helpful to separate the nephrotoxic as well as the vasoconstrictive effects of contrast in the kidneys. No doubt both of these play a role. The normal kidneys respond with vasodilatation with contrast. And when the kidneys are diseased, whether it be with diabetes, reduced renal parenchymal mass, and reduced GFR, what I want you to know is that kidneys that are diseased to begin with behave paradoxically when exposed to contrast, particularly this sustained vasoconstriction. We believe renin-angiotensin, endothelin, reductions in nitric oxide and prostaglandins play a role in this. There is tubular injury. Now, the good news is there's also tubular recovery. And as a general rule, the acute kidney injury that occurs is recoverable after exposure to contrast. Now, we know renal function itself is a wonderful risk stratifier. Look at these data from the Cadillac trial. These are all patients with ST segment elevation myocardial infarction. So the infarcts are all the same, but creatinine clearance greater than 60, nearly a perfect survival. Creatinine clearance less than 20 out to a year, the survival is markedly different, 40% mortality rate. So renal function, the best stratifier of survival after acute MI, much better than left ventricular ejection fraction, troponin, or any of our cardiacs. Now, on top of that is the issue of acute kidney injury. In the same study, if contrast-induced acute kidney injury was present, there was a 16% mortality compared to 1.2% mortality without acute kidney injury, and that translated to a year. Every study that's looked at this has found the same effect. It is wonderful to not have acute kidney injury and have a terrific survival. Acute kidney injury is clearly a proxy for something, vulnerability, susceptibility. It has lots of kind of conjoined factors, but we believe the acute kidney injury itself probably plays a role in the pathogenesis of outcomes. And this is shown in a broader group from the cath PCI registry. Now, this is both elective and urgent catheterization. You can see the striking relationship between having no acute kidney injury, some, and then those who end up on dialysis after the procedure is very rare. But a patient who ends up on dialysis after a procedure has, in the PCI registry, over 30% mortality. I want you to understand that. There's also, again, as a proxy for frailness and sick patients, bleeding is higher, and then also rates of recurrent myocardial infarction are higher. Adjusted AKI, established quality metric, and so at the 50th percentile, this should occur in hospitals at about 6% of all cases. Now, the 90th percentile, what could it be reduced to optimally? It could be as low as 2.85%. So there is an opportunity to reduce it with quality measures. Now, the pathophysiology of what occurs, I've mentioned about this direct chemotoxicity of the contrast. This is where we have an opportunity to make a choice in contrast, as well as a vasoconstrictive effect. But once the contrast is in the kidneys, there probably is cell-to-cell death through processes of oxidative stress and injury. The action is all in the tubules. It's not a glomerular injury, and it's not in the collecting ducts. It's in the tubules where there's been enough research to show that we have a variety of blood factors that are measurable in research. These what's called tubular markers of injury. We see reductions in filtration. Our two filtration markers are creatinine and cystatin C. None of these markers, unfortunately, have come to the front to really help us clinically, outside of potentially L-type fatty acid binding protein that's being commercially used in Japan and is kind of the lead marker in contrast-induced acute kidney injury. I mentioned tubular recovery, which is wonderful. These proximal and distal convoluted tubules get injured, and they do have the ability to recover. There are recovery cells here. So much of our care in this is supportive. If we could ever find a way of actually having regeneration and not allowing these tubules to become completely necrotic or fractured, that would be a wonderful way of preserving nephron mass. Our group has published this important point about adding non-cardiac surgery. When we do an angiogram, And then we follow on with cardiac surgery very tightly in time. That's the bottom curve here. We have an excess hazard for major adverse renal and cardiac events, including renal replacement therapy, MI, stroke, heart failure, hospitalization, and death. And if we can space out the catheterization from the surgery, 5 days or more, we can get to a much more acceptable curve. I know a lot of this is confounding the cases we do urgently, but if there's ever an opportunity to wait between an angiogram and cardiac surgery, multiple studies show that. How can we prevent contrast-induced acute kidney injury? Well, first thing we do is we recognize risk. People with negligible risk, a 50-year-old individual, no comorbidities, very low risk, we don't really need to do anything. But an 80-year-old who has diabetes, kidney disease, left ventricular dysfunction presents with an ST segment elevation of my person at much higher risk. And so risk stratification is important. Giving a pre-procedural volume, isotonic crystallite, normal saline, or Ringer's lactate, or plasmolite, those are all very reasonable things to do. Making sure patients continue their statins before and afterwards, stopping nephrotoxic drugs. I mentioned various other things that can be done. There are device-based interventions, including interventions that reduce the degree of contrast exposure. We have contrast sparing strategies to, again, try to limit the amount of contrast. And then we have advanced forms of non-contrast coronary injury. Outside of hydration and choice of contrast, most of these, unfortunately, despite all the efforts, have not translated to improved outcomes. The radial artery catheterization is worth talking about since it's so frequently used, and the data suggests from the Matrix AKI program that every time we look at it, the radial artery catheterization is in blue. There is a slight advantage in terms of any way we classify acute kidney injury. And this is probably due, and radial artery catheterization is on the rise, probably due to the fact that we use smaller catheters and do not cross the aorta at the level of the renal arteries. There's a clear trend that contrast-induced acute kidney injury is going down over time. This continues despite increased risk in patients. And I think this is because of our selection of lower risk contrast, minimization of contrast, hydration, and smaller catheters. And this is wonderful. The rate, as you can see here, dropping over time and continues to do so. There is a role of contrast, and we've published on this. What I'd want you to know is that when we look at head-to-head trials, when we give intra-arterial contrast, what really counts, the overall pooled hazard is 0.46 in the clinical studies, about a 60% reduction in contrast acute kidney injury with isoosmolar contrast as opposed to low osmolar contrast. So it's all about risk stratification and using it in the right individuals. When we apply this broadly across huge sample size and outcomes, you can see these relative risk reductions. While the cardiac events are responsive to the use of low osmolar contrast, it's always the renal composite that's most responsive. So we choose isoosmolar contrast for its overall renal safety profile primarily. We know there's an advantage from reduced numbers of allergic events as well, but far more than the cardiac events. They all move in the right direction. Intravenous fluid, I mentioned, we rely on the Poseidon trial, which tested this idea of measuring left ventricular end diastolic pressure or understanding this clinically, and simply giving 3 ml per kilogram bolus in the pre-procedure phase, and then continuing this intravenous volume expansion through the procedure. You can see the rates just beforehand and 4 hours afterwards during recovery. This is related to a significant reduction in the primary event rate. Many patients are just volume contracted, and when we give some volume, we don't put patients into heart failure. In my view, we don't need to measure left ventricular end diastolic pressure unless there's a clinical question. We can safely give pre-procedure fluids and a short duration of fluids afterwards, and it makes a difference compared to not doing so. N-acetylcysteine, an antioxidant, has been sufficiently disproven. The PRESERVE trial, very large Veterans Administration trial, no supportive data support this. No supportive data for bicarbonate for that matter as well. So we can simply use normal saline or Ringer's lactate. So to finish and conclude, the points I've made is that contrast-induced acute kidney injury is amenable to risk stratification, and we can follow this type of algorithm. If the estimated GFR is over 60 mLs per kilogram per minute or creatinine that an individual views as acceptable, nothing else needs to be done. When the estimated GFR is 30 to 59, that's when we start having various interventions that we've mentioned, including volume expansion, including in higher risk patients, beginning to restrict potentially nephrotoxic drugs. We always ensure statin use because the data in the randomized data suggests statins have a beneficial effect on the kidneys. And when the estimated GFR is below 30, that's really a strong call for hospital admission, certainly use osmolar contrast and limiting the contrast exposure. This has really been bedrock, and I think this has been one of the reasons why we've done well in reducing the rates of acute kidney injury over time. The adjunctive drugs, unfortunately, don't work. It's all about the procedure, the choice of contrast, and intravenous volume expansion. What we're really trying to get to is the pivotal question. I think this may have been answered in some of the recent data sets, that if we prevent contrast-induced acute kidney injury, can we drop these rates of clinically meaningful events, death, dialysis, rehospitalization, heart failure, acute coronary syndrome, arrhythmias, and stroke, even though they're not directly causally related to the acute kidney injury event. The idea is we take all these principles, what we call the precautionary principle, and it does seem to work as a package for a safer procedure. And changing the long-term prognosis and by what mechanisms, that's all part of the research in this area. But I think it's a happy story that we've made a tremendous amount of progress in this area. So I'll stop here, and that ends my talk. And I will be delighted to entertain questions as feasible in the program. Thank you.
Next up, and equally impressive, is Professor Emmanouil Brilakis, who's director of the Center for Complex Coronary Interventions at the Minneapolis Heart Institute. Dr. Brilakis leads a large clinical trial group investigating, among other issues, the treatment of chronic total occlusions, or CTOs, addressing saphenous vein graft disease, intracoronary imaging, antiplatelet treatment optimization, cath lab radiation safety, and implementation of novel technologies in healthcare. He's also a hugely productive author of peer-reviewed manuscripts and wrote the Manual of Percutaneous Coronary Interventions and the Manual of CTO Interventions, now in its second edition. He's on the board of the Cardiovascular Innovations Foundation and an associate editor for Circulation. Welcome, Professor Brilakis.
I would like to thank Dr. Sackier for the great introduction and proceed with discussing about the risk of acute kidney injury in the cath lab and about how to potentially prevent it. There is a recent document from Sky outlining what is complex PCI, which has to do with anatomy, has to do with the patient's comorbidities, as well as the equipment and techniques that we use in the cardiac cath lab. And any of those components, or quite often many of those components in combination, can actually translate to increased risk of doing a procedure as well as increased complexity. For example, performing a CTO in a patient with comorbidities such as heart failure, a patient who may require atherectomy, all these things might increase the risk of the procedure and the risk of associated complications. There are different types of complex subsets, including the ostial lesions, bifurcation, left main, calcification, thrombus, CTOs, balloon uncrossable and undilatable lesions, and also PCI in complex lesion subgroups, such as patients with previous TAVR, as well as patients with cardiogenic shock. How can we predict the risk of contrast-induced acute kidney injury? There are multiple scores. One of the first ones, and highly commonly used, is the Meran schema, that use several factors, including the patient's pressure, hypotension, use of balloon pump, congestive heart failure, age, as well as the baseline creatinine, to calculate a score for contrast-induced nephropathy. This is an example of several of the contemporary series of CTO interventions, one of the most complex subsets of interventional lesions in interventional cardiology. And what we can see is that success is actually fairly high, 85 to 90%, and complication rates are overall low. But if we look at the amount of contrast that it takes to actually perform those procedures, it is fairly substantial. It is anywhere between 200 and 350 or 400, with most of the series around 280 and to 300 cc's of contrast. So a lot of contrast comes in, and this is just the mean. Some of the cases have a large amount of contrast, which increase the risk of contrast nephropathy. We also know that if in CTO intervention or any intervention, you end up developing contrast-induced acute kidney injury, then your risk for subsequent complications goes up, including the risk for requiring dialysis, as well as the risk for subsequent adverse events. There was a recent meta-analysis by Francesco Moroni and Lorenzo Cellini showing that, especially in patients who have a baseline kidney disease, their subsequent outcomes are much worse than those who do not, both in terms of the acute procedural outcomes, technical success, technical failure, and in-hospital death, but also in terms of other complications such as major bleeding, CI, AKI, as well as all-cause mortality during follow-up. So complex procedures are placing the patient at risk for developing CI, AKI, which in turn translates to multiple other adverse outcomes, and therefore it is very important to take every potential measure to prevent this complication. And we can break those down into 3 time periods. The first one is before the procedure, the second during the procedure, and the third one after the procedure. So hydration is a mainstay for preventing contrast nephropathy. It does not matter whether we give normal saline or bicarbonate for preventing CI, AKI, they're equivalent. So most places give normal saline. And if one uses LBDP guidance, this can actually translate in a lesser risk of contrast-induced nephropathy. So hydration is something to plan for. In some patients, we'll admit them actually before and provide them with several hours of hydration to optimize the intravascular status. Also, before we start the procedure, it is extremely helpful to know what margin of safety we have. And that has to do with the patient's creatinine and GFR. We do know that if we exceed certain thresholds of contrast volume for the procedure, then the risk of having kidney issues increases. And those thresholds vary. In general, the lower the volume of contrast, the better. But if one can keep it definitely under 3.7 times the eGFR, but ideally under 2 times the GFR, that significantly cuts back on the risk of CI, AKI. And this is especially true in patients who are starting with baseline kidney insufficiency. How about during the procedure? What can we do during the procedure to minimize the risk? The first one that makes sense is to decrease the contrast volume. How can we do that? We can do that by following algorithms. This is an example of a global CTO crossing algorithm that was just published in JACC that has now been globally accepted as one way of following a step-by-step approach for CTO PCI and maximizing the chance of success in the most efficient and safe way as well. So following pre-designed protocols such as this one for CTOs or other complex procedures can help streamline the procedure and reduce the amount of contrast requiring during the procedure. Also, it is important to use other measures. For example, biplane angiography, if available, can cut the volume of contrast that we give by half. It does have some difficulties, but it can be very useful. Also, there is no need to give massive injections. Limiting the volume of contrast per injection is very important. And also, having the frame review, having a safe frame next to our live fluoro can help guide the interventionalist for positioning equipment without necessarily having to administer a contrast. Sometimes we dilute the contrast media. We should always try to minimize the test injections and also use other techniques. For example, use the stent boost or clear stent techniques to better visualize the stents so we don't have to give contrast to determine if our balloon is inside those stents. If we do use high acquisition rates, then the image quality can improve, and sometimes that can reduce the number of acquisitions we have to take. And also it's best to prevent the contrast that's in the catheter from going into the system, into the patient, when we're advancing or removing catheters. And I will show you an example. This is an example of how we can minimize the contrast. We can see that every time that we advance the wire inside the catheter, the little bit of contrast keeps on coming into the system. So it's best to first aspirate before we actually insert wires to insert or remove guide catheters inside the body. There are other ways we can reduce the contrast volume using a roadmap and also using intravascular ultrasound. OCT is generally avoided because we require contrast administration, but IVUS can be extremely useful to ensure a good stent optimization and minimize the amount of contrast that we give. There are also systems such as the divert that can help reduce the volume of contrast. In a preliminary study we did in CTO PCIs with 2 of those systems, giving the dual injection needed for those procedures, there was about 20% lower contrast volume needed for those patients. IVUS can be very important, also significant reduction in the contrast volume in the Mozart study when IVUS was used for guiding PCI. The other way we can reduce the risk of acute kidney injury is by selecting different types of contrast. Specifically, the ISO smaller contrast agents are associated with less risk of adverse events, less risk for CI, AKI, and other adverse events. There was a large study from the Premier database that looked at use of ISO smaller contrast in a very large number of procedures, representing about 1/5 of the US hospitals. And after adjustment, what they showed is there was about 10% reduction in the risk of Marseille, significant reduction, about 50% in the renal composite outcome, and also reductions in other outcomes. So ISO smaller contrast agents were associated with lower incidence of adverse events. This is also an analysis from the Premier database that specifically looks at complex procedures and the type of contrast used. And what we can see that in patients, for example, with CTOs, there was a significant reduction of the risk of Marseille. And the same goes true in patients who had diabetes, in patients who had chronic kidney disease, and especially patients who had a combination of those factors, either all 3 of them, diabetes, CKD, and CTO, or any 2 of those. So especially for patients who are at the increased risk of complications due to baseline diabetes, baseline chronic kidney disease, or undergoing complex procedures such as CTO, ISO smaller contrast media did reduce the risk of having adverse major renal and cardiac events. So to summarize, complex PCI is here to stay. We're seeing actually an increase in the number of those complex procedures with improving outcomes. But one of their Achilles heel is the large amount of contrast that is often needed to perform these complex procedures. And this risk can increase the risk for CI, AKI, as well as MACE adverse events. So ways to minimize this is to provide the patient with hydration, both before and after the procedure, limit the volume of contrast using imaging and roadmaps to achieve that, and finally, by using ISO smaller contrast media. Thank you very much.
So, gentlemen, thank you both for excellent and very comprehensive presentations. We're now going to embark, ladies and gentlemen, on a structured discussion, and we'll then take live questions from you, our audience. So please post them via the question link that you'll see at the bottom of the screen, and we'll do our best to get to them at the end. So I'd like to start talking about the awareness of the condition. As I said at the beginning, I'm just a surgeon, but in preparation for this webinar, I chatted to some of my friends who, like you, work in this space, and I heard from some quarters that acute kidney injury in this setting isn't a problem or doesn't exist. Can you explain why there's a growing awareness about this cath lab problem and what we can do actually to improve awareness? Who would like to go first?
Yeah, I'll be happy to tackle that. And I'd say that patients are the least aware. So the average patient who undergoes a contrast-based procedure like a heart catheterization has almost no knowledge, despite it being in the consent form, that the contrast and the procedure itself can be related to acute kidney injury. Some consent forms even mention the word dialysis on them. It still is not in the range of awareness or typically in the discussion that the patient has. Unfortunately, many doctors, particularly those who are really focused on the procedure, want good news. And the best news they can have is the getting through the procedure and having a good anatomic result, a good functional result for the patient. And then the serum creatinine becomes the bad news after the procedure.
Emmanouil, do you have any comments?
Yeah, no, I agree with Peter. And it is true that we do not have always the full awareness. And the problem with this complication is that it happens usually a few days later. It doesn't happen immediately. So for many proceduralists, you're focused, as Dr. McCullough said, you're focused mainly on the acute outcome, how to get the best result. And then when the procedure is over, the contrast is given, now it's too late, and then it's just a matter of time until the consequences manifest or not. So it is a change of mind. It's not just the acute complications, which are of course very important, but it's also to focus on what can go wrong in the next several days in a much less spectacular way. A perforation is something very obvious, very concrete. Everyone knows about it. But having creatinine slowly go up over the next few days is not as dramatic until the patient gets for dialysis, when it does become dramatic, but then it is too late. So I think that difference between the time it happens and the time it actually manifests is what makes it less obvious for people performing procedures.
It's always important. The idea of informed consent, of course, is problematic because no one's going to be as informed about this procedure as, the patients aren't going to be as informed as their interventionist. But we have to do a good job setting out the risk benefit of having a procedure and the risk mitigation, right? The steps that, here's a problem, here are the steps which you both addressed that we can take to mitigate that. Do you think that there's a lack of awareness of acute kidney injury amongst those doing the procedures rather than those lying on the table?
I think it's clearly in the minds of individuals in the background. For instance, I just saw a patient yesterday with severe heart failure. We have evidence now that she has almost certainly coronary heart disease contributing to her heart failure, but she's so breathless. She has an ICD in place. She can barely lay flat. I have to tell you, my immediate concern is, can she even get through the catheter-based procedure right now from a cardiovascular perspective? And then farther away in my mind is the renal risk, which I know is very real, given background history of diabetes, chronic kidney disease, heart failure, anemia, etc. So I know it's there, but I agree with Dr. Brilakis that it seems like there's a hierarchy of what we're worried about in catheter-based procedures. And the single greatest thing we're worried about is survival through the procedure, especially in very high-risk patients.
But again, it's important to put this into perspective. And I'm going to come on to this later. You're talking about looking after people who are profoundly unwell and without your interventions may well die. But we're going to come on to that. Do you have anything to add to that, Emmanouil, about educating, about getting doctors to do a better job to think about this and communicate it?
Yeah, absolutely. I think in my mind, this eventually comes to us because once you hear the patient goes on dialysis, then it's a very dramatic event and sometimes it's unexpected. So eventually, I think there is awareness of it, but having the awareness early on before the procedure is the key. I mean, you don't want to have the awareness later on. You want to be aware of it at the beginning of the case. And that's why, as we'll probably discuss in the presentation, we'll discuss later on, having the timeout and saying, look, the GFR is XYZ, the creatinine is XYZ, helps bring to awareness that, hey, this is a potential problem. Let's do whatever we can now to avoid having this problem later.
Yeah, they say in surgery, there's no such thing as small operations, just small surgeons. So, Peter, you were an author on a paper that I read called Measuring the Variation in the Prevention and Treatment of CI-AKI Among Interventional Cardiologists, that was published in Current Problems in Cardiology. Could you tell us about the key findings from this publication and why it's relevant to what we've been talking about?
There's been tremendous work done with respect to randomized trials of almost every aspect of contrast-based procedures. But one of the things that I think everybody likes to see is what we call reduction to practice. Can we actually put all these concepts together and change things at an individual center level? And what we found in a consortium of hospitals is that there was a tremendous variation in terms of the actual rates of contrast-associated acute kidney injury. And so when we see different rates among different hospitals, we have to take a much different analytic approach because we know all the ingredients of risk are present, including differences in patient characteristics from hospital to hospital, the choice of contrast, the volume of contrast used, a variety of different approaches. But the thing we're most interested in is do the hospitals actually take a systematic approach to reduce risk? And one of the things that can be done is the use of adjunctive intravenous fluid given before the procedure and during the procedure in higher risk patients. And then we're very interested in the selection of contrast and the volume of contrast utilized. And so, in fact, those variables are determinants of hospitals that have either higher or lower rates of acute kidney injury.
And I think it more broadly speaks to the value of internal audit and public transparency about our performance in every intervention in medicine. We owe that to our patients. So, Emmanouil, I'd like to go to you and talk about high-risk procedures like CTO, the characteristics of at-risk patients, the role of contrast media, volume in such procedures, which you mentioned. So can we start with you?
Yes. So what we have seen in the last few years, and actually it's a trend that will likely continue in the future, is that the procedures we do, the PCIs, are becoming increasingly complex. This has to do with the patient surviving longer, to improve therapies, medical therapies better, revascularization procedures are better. So actually patients are living longer and longer lives. And as a result, when they come back to us, they often have a lot of problems, comorbidities. The older they are, then the more likely to have CKD, more likely to have diabetes, frailty. So that increases the risk of the procedure. But also, we are now tackling increasingly complex anatomic subsets. So CTOs is a classic example. 10 years ago, it was done by a handful of people. Right now, it's a procedure done routinely in many centers around the world with actually continually improving outcomes. So complexity is here to stay. And just getting ready for addressing this complexity in many ways, both on terms of CI, AKI, but also in terms of the technical aspects of the procedure is there. Because it's so complex sometimes procedurally, sometimes the contrast aspects fall on the background. And that's the thing to not do that. Actually, because of the radiation coming less with newer machines, now contrast should become, in my mind, one of the more important limiting factors of when to stop. Because sometimes things don't work, and being aware of the potential issues of contrast nephropathy should be a trigger for stopping the procedure and coming back another day when the risk is going to be less.
Yes, it was very elegantly addressed in the talk about mitigating the amount of contrast being used. So thank you for that. Peter, I'd like to ask you a question about risk scoring. How, very often these tools are fantastic and they appear in papers, but in real life, not so much. How often do you see risk scoring being utilized in the real world?
They're used in terms of clinical judgment. I think the ones that are readily apparent when a patient is scheduled for a procedure, including the baseline serum creatinine and calculated estimated GFR, the presence of diabetes, the presence of heart failure. I think those that are readily apparent. The difficulty with risk scores, a lot of times they throw in additional variables that can only be known after the fact, including whether or not a balloon pump was needed, or how much contrast was administered, or if there was any intra-procedural hemodynamic changes. Well, I mean, those are things after the fact. So I've been a proponent of risk scores that are practical, that can actually be applied before the procedure, at least to have better informed consent. So an individual can know what their risks are. For example, when the risks in any cardiovascular procedure become more than 5%, by our guidelines and by inference with respect to other like surgical procedures, we would consider that high risk. So if there was a chance of greater than 5% of having contrast-induced acute kidney injury, or certainly ending up on dialysis or worse, that would be considered a high-risk procedure. We know that the overall rate in the American College of Cardiology National Procedural Registry, NDR, that the overall median rate of contrast-induced acute kidney injury is about 6%. So we have about half the hospitals on average below that, half above it.
Right. Emmanouil, do you have anything to add to that?
I agree that the scores are useful, but the problem with scores is, for example, for CTO, we have a CTO success score, many of them. We do have CTO complication score. Now you have the score for nephropathy. There are other complications as well. So the reality of it is that in the cath lab, you cannot have 20 scores listed on the board because they do lose their meaning at some point. For my mind, instead of, at least for what we do in our practice, is instead of putting the scores on the board, we do make it a part of the timeout to say the GFR. And again, that's not, perfect. It's not as accurate and having all the parameters, but gives you a sense how urgent and how important it is to limit the risk of contrast nephropathy.
Yeah, and the more we can do as a profession to share these objective measures, again, it also inures to better outcomes for our patients. Let's stay with you, Emmanouil, for a second to talk about the impact on dialysis and hospital stay of contrast-induced AKI.
Dialysis is obviously a dramatic event. I mean, it's one thing to have a laboratory number, creatinine slowly go up and then come down. But once you get to dialysis, that's obviously something big. You need another access point. The patients are going to stay in the hospital for many more days. The risk of other complications go up. And as you've heard from before, it's not just the kidney issues, but sometimes the precipitating factor is something we did not know. For example, I had a patient a few weeks ago who had a major bleed during the procedure. Hemodynamics dropped. And even though we didn't use a huge amount of contrast, the patient still ended up going on dialysis. So it is the unknown component, and it is a dramatic event. And when it happens, unfortunately, it's too late. So having, good luck is important, but planning to any degree possible by having everything ready, treating any hemodynamic derangement as quickly as possible can help, again, prevent us from getting to the point of dialysis. The good news is sometimes dialysis is temporary and the patients actually recover, and that's the best outcome. But there are several patients who unfortunately do not have that recovery and remain on dialysis.
So first of all, thank you for sharing a bad experience. My favorite experience at a surgical meeting was when one of my colleagues showed a compilation of things that had gone wrong. We learn much more from the tough cases than the easy ones. Peter, I saw you nodding sagely. Do you have something to add to what Emmanouil had to say?
I was trying to think across my clinical practice over the years. I only have a handful of patients who directly ended up on dialysis as a result of a contrast procedure. And I've been following this very closely. I think we're entering our 4th decade now of interventional cardiology. And one of the things I've been gratified to see is that procedures done periodically over the course of one's life with contrast do not appear to have a significant cumulative risk for the progression of kidney disease. I know this is debatable in the literature, but I think the kidney disease is much more driven by the underlying processes such as hypertension and diabetes and not intermittent use of contrast. We know that the tubular cells, the proximal and distal tubular cells in the kidneys, they do have a recovery ability. They have the ability to actually regenerate after injury, provided the initial injury is not so severe. So what we're seeing is when there are these minor increases in serum creatinine and transient reductions in renal function, it's not destroying the kidneys. Patients do bounce back. And I'm hopeful that if we have good practices, like Dr. Brilakis has said, the ability to basically stop, particularly with attempts on complete revascularization. We have a whole variety of trials that suggest that once the culprit artery is open, for instance, in acute ischemic syndromes, to actually go improve the other vessels when they're severely narrowed is supported by the data. And I think there just needs to be a limitation there, and that is the amount of contrast volume and how much that patient can tolerate on the table.
So, Emmanouil, I want to come back to something you said. You said CTO is now being done globally, and these are considered complex procedures. Can you just briefly tell us what percentage of cases are now complex, high-risk procedures?
This is a great point, and it all depends on how you define complex. We actually did an analysis a couple of years back from our institution looking at various levels of complexity, like low ejection fraction, bifurcations, calcium, CTOs, and actually more than half of the cases were complex to one extent or another. Now, the CTOs per se are about 5 to 10% of procedures. So as a percentage, they're not a huge percentage, but it is growing. And in terms of procedural allocation, in terms of time requirements, equipment, these take a lot more time and they require much more efforts than other procedures as well. So it depends where you practice, depends on the referral basis, depends on the complexity of the local patients. I think sometimes in the US, we do have a lot of patients who have diabetes, morbid obesity, some factors not necessarily found everywhere in the world, but it is growing, and I think it will continue to grow in years to come.
Yeah, my guess is that if we repeated this in a few years' time, these will become blasé. You'll have mastered them. So I'd like to bounce backwards and forwards between the two of you on the most common risk mitigation factors that you see being employed, and where could we do better? Each take a turn, throw something out there. Peter, you go first.
I'll take choice of contrast, and the big choice of contrast is either isoosmolar contrast or low osmolar contrast, and there's a tremendous hospital variation. We've published across the United States using a variety of big databases showing some hospitals 100% of the time use isoosmolar contrast. Others actually don't even have it stocked on the shelf. In general, there's a blend. Most hospitals use about 25% isoosmolar contrast, but choosing that contrast for patients at the highest risk, in my view, I think is well supported by the data, meta-analyses of randomized trials, of head-to-head randomized trials that have systematic assessment of the serum creatinine support that decision in patients with underlying CKD and diabetes.
So the audience who are listening who aren't using it, read the papers. Emmanouil, your choice.
I agree with what is said already, and I think additional factors is the volume of contrast. So you want to use, obviously, especially for the high-risk patients, smaller, but also you want to be very cognizant at how much contrast we use. And there are various techniques, as discussed in my talk, you can do that. Less injections using intravascular imaging, staging the lesion if you have multiple lesions. So minimizing the volume of contrast is another way to minimize the risk of CI-AKI.
So basically live to fight another day, if necessary. Peter?
I would add to that we've published from our group this issue of performing a diagnostic cath and finding multivessel disease where a patient needs bypass surgery. And I know it's confounded by a lot of clinical factors, but what we showed, if a patient is moved basically within the same day from an angiogram into a bypass surgery, that's very high risk for acute kidney injury, as well as other serious events afterwards, what we call major adverse renal and cardiac events. And this idea of live to fight another day, I think, is really important. We found, as Meta has found in previous analyses, that if we get about 5 days from the diagnostic procedure to the bypass surgery, in a sense, there's a rest period, a recovery period, and then the risks appear to be much lower.
Yeah. So a brief word on real world evidence. Being widely used in many places. Comments, guys?
We have the 21st Century Cures Act, and I think a lot of people rely on that now. That's actually a law in the United States that we are required to look at all forms of evidence, not just randomized trials. It's been estimated in cardiology that we have randomized trials and guidelines to only support about 6% of our decision making. 94% involves clinical judgment. You're nodding your head as a surgeon. I know surgeons in the operating room, they have to make a lot of edge decisions. They don't have randomized trials for every time you're going to take a certain move around a corner or put in a particular stitch. The same thing in interventional cardiology. I have great respect for the interventional cardiologists in the cath lab. They are very much like surgeons, and the cath lab is very much like a super operating room where the procedures done there have all the elegance and skill of what a surgeon can do, but they also have complex physiologic assessments and a lot of data coming to the doctor minute by minute, and Dr. Brilakis can comment more on that.
Concur, Emmanouil?
No, I agree. And actually, we did look even at the guidelines, the ACCHA guidelines a few years back. And as you said, it's only the minority, less than 20% of the recommendations that had actually a level 1 recommendation. The majority were observational studies or expert opinion. So there's no question that we will never have all the trials we want to make every decision that we can. And we just have to use our judgment to make the best of what we currently have.
Well, I could go on asking questions till the cows come home. I'm fascinated by this topic, and this has been a great conversation. It's been my prerogative, if you will, as chairing this webinar to ask these questions. What we're now going to do is throw to our live audience so that they can pose their questions. And again, please continue to post them. We'll do our best to get round to as many as possible. But for this phase of the discussion, chaps, thank you very much. I will go to bed a lot less done tonight. I do notice some questions have come in, and we'll do our best to get through as many of them as possible. So first up, what do you think is the best approach to follow patients, excuse me, that are discharged earlier than the usual peak of serum creatinine? Maybe those at risk are usually admitted for several days. Who wants to go first?
I mean, I'm happy to get started. I think this is something very, very important. As you say, we rarely keep patients for too long. And quite often, especially if it's a diagnostic procedure, patients may go home the same day. What we routinely do is have the patients follow up in 48 to 72 hours with a repeat metabolic panel, studying creatinine clearance, and basic electrolytes to see if there has been any difference, so that if there has been some impact on the kidney function, it can be diagnosed early and measures taken to minimize the consequences.
Peter, additional thoughts?
There's some innovation. I'll just point in the future of just launched a large study of using an innovative biomarker called L-type fatty acid binding protein, which is interesting because we can measure it before the procedure. It looks like a risk predictor. And then after the procedure, it may be a leading indicator of acute kidney injury. So those of you who are, there's a multi-center study interested in participating, please reach out to me after the program. The Japanese have innovated with it. As Dr. Brilakis says, we try to use our judgment and have follow-up serum creatinine or BUN, but we're very much looking for a short-term test we could do in the post-procedure timeframe and know if patients are all clear or not. That's what we're trying to get to.
So next up, and I'm going to be very brief with these so we can get through as many as possible. And keep questions coming in, folks. What is, in your opinion, the target to achieve in the incidence of AKI according to the CDR registry?
Well, the ACC-NDR, the registry has a median at 6%, and has, I believe, the upper end is about 2%. So it is achievable to get to about a 2% rate of contrast-induced acute kidney injury. I think a lot of that, honestly, is case selection. And I think for simple procedures that are not complex and certainly not CTOs, where the contrast volume is kept low, and also kind of lower risk centers. Both of us are at bigger tertiary care centers. About 2/3 of our patients come from outside of our region. They come in by helicopter or by ambulance all day long. So already they're coming in for escalation of care. So our case mix is different. But people should hold on to 6% median and maybe keep it down, if they could, down to 2% with really good care.
No, and I agree. To me, the number is kind of arbitrary, as you heard. I mean, it depends on the patients you do. If you do only simple patients without any comorbidities, you're going to keep it 0, but maybe you don't help the ones who have some baseline kidney problems to start with. So, I mean, obviously 0 is the goal in general, but in patients who come in and have multiple comorbidities, cardiogenic shock, complex procedures, that's probably unrealistic. And trying to keep it less than 5-6% is, I think, a reasonable target.
So next up, use of NGAL, NGAL, and cystatin as biomarkers for kidney injury.
Yeah, I'll take that one. I think NGAL has had good performance in the ICU as in sepsis, and it is available as a laboratory-derived assay. It's actually used routinely at University of Cincinnati. The problem with NGAL is as constitutively produced, meaning patients with kidney disease can produce many-fold higher baseline level than someone without kidney disease. So we have to look at the relative change, but it does have indications there. It is performed poorly in contrast, and I can tell you, I think that, as well as cystatin C, which is in serum, it's a filtration marker, but it can be measured in urine as a tubular injury marker as well. That also has failed poorly. So we're looking forward to having probably the first contrast marker with L-type fatty acid binding protein.
Okay, so Emmanouil, I'm not going to give you a chance to add comments because he did such a lovely job. Comments on device-assisted hydration. Do you want to take that?
Yeah, absolutely. So hydration has been very generic. There's some studies showing that it doesn't matter if you give bicarbonate, if you give normal saline. So I think most people now give normal saline. Now, there is LVDP guided hydration, which is a little safer because then you try to minimize, you optimize the volume of saline administration to the patient's baseline hemodynamics, and that can work. There's also systems where they essentially cause a hyperdiuresis by monitoring the urine output, causing diuresis with Lasix, and then replacing the fluid as it comes out. And those are very good. The challenge with that is it requires a Foley catheter. It's a little cumbersome setup, and I think that's why many people have not necessarily adopted it, but it's promising in terms of the clinical outcomes. So there are ways to optimize. I think one has to be very careful in patients with underlying cardiomyopathy, high filling pressures to start with, but there's a lot of room for improvement there. Our precision in giving the accurate volume of normal saline to those patients.
Yeah, and I know it's being deployed in other clinical circumstances as well, I think to good effect. What's the risk of CI-AKI in staged procedures?
Well, maybe I can start by saying, so we used to think that let's do everything and get everything done because you minimize the access. If you have a stage procedure, that means you're getting access twice, so the risk of access complication is double. But we've come now to terms that sometimes trying to do it all ends up being worse, not only in terms of the acute kidney injury, but also for other potential, like radiation. You can get radiation burn if you give a high radiation dose. And the patients may be tired, may have some movements during the procedure, and then end up having a complication that you wouldn't necessarily have otherwise. So I think most of us, especially complex operators, are very cognizant of this, and they truly try to minimize it. If things are very hard or things become harder than you expect in the beginning, they have a low threshold to say, as you said before, let's fight another day, let's stop now, let the patient recover. There's no emergency, bring them back in a few weeks, and then we'll keep on working.
Comment, Peter?
I've been following this literature closely. I've been impressed with the skill of the interventionalist to decide when to stop and when to do more complete revascularization. The randomized trials in general support more complete revascularization than just culprit vessel in acute coronary syndromes and of all different types at this point in time. The key is this clinical judgment. It looks like the clinical judgment beats the randomized trial in terms of outcomes. And so the interventionalist is factoring not only the contrast load, but the overall tolerability, left ventricular dysfunction, thrombosis risk, dissection risks, and dissection management if it happens. So the bottom line is the listeners can expect more complete revascularization. In fact, we want to see that, but we want to see it safely. And I think when there is a rest period of more than 5 days, if it can be done, would be better than trying to stack it just a few days later.
The whole incorporation of real-world evidence, personal experience, and good communication with our colleagues so that we bring the best possible solutions to patients. So, pithy answer. How real is CI-AKI actually, and why does it seem to be a growing problem in the cath lab? Is it that patients are getting sicker? Are we getting smarter?
Yeah, I'll take that. It's a real problem, but I think out of all the acute kidney injury, I think it's the most manageable. It's amenable to risk stratification, and I think it has less serious implications than sepsis, acute kidney injury, or other forms of that illness. Unless we get deep and sustained injury with tubular fracture, the pathologists, the renal pathologists tell us in real acute kidney injury that's serious, the tubules are permanently fractured. They actually don't heal. In contrast, because we don't have such a violent damage to the kidneys, if we can manage patients through it, the tubules regenerate and we're fine.
I think it is what you have the tools. Like we have tools to prevent this. For some other things we don't, like sepsis, as you heard before. So because we have tools to prevent it and techniques and strategies, that's why it's important to implement them on time to avoid this having down the line.
We talk about high-risk patients. What are we talking about? Patient characteristics, procedure type, both?
I think it's both. I mean, the patients we're seeing in the cath lab are much, especially in the United States, are much more complex. They're much more obese. The diabetes is higher. The ejection fraction is lower. Their age is older. So the patients are older, but also their geographic parameters. There is more calcium, more bifurcations, more left main. And the things we can do these days are much more involved and much more complex than what we can do even a few years back. So the combination of geographic complexity and comorbidities is, I think, what makes it more prone to complications, including CI-AKI.
I would add just briefly, I think these periods of sustained hemodynamic instability, I always worry about post-cardiac arrest patients where we've done CPR or they've gotten very sick in the cath lab and been hypotensive and we had to rush to put a balloon pump in. I think those patients, everybody's doing everything they can possible, but they're the ones that have a significant rise in creatinine afterwards.
As the patients get sicker and you guys get better at what we do, it's inevitable we'll see this. So in a few seconds, I'm going to put you on the spot and ask for a takeaway comment. So if everyone didn't hear anything that's been said in the past hour, they'll have a takeaway. So while you're ruminating on that, I want to say a few thank yous because unfortunately, this is all we've got the time for. I want to thank both of you for your great presentations, great discussion, and you've been a delight to work with, both of you. So thank you. And I certainly feel like I've got a better understanding of CI-AKI in cath lab procedures and hope that you our audience feel the same way, and we'll take this into consideration going forwards as you look after patients. I'd also like to thank EMG for hosting this event and GE Healthcare for their support. And of course, thank you, our audience, for taking the time to watch and for all you do for patients. So before we say goodbye, who wants to go first with a pithy comment?
I'll go first and just say that I think every patient I've ever dealt with is very appreciative when the doctor cares about taking a few extra steps to protect against complications such as kidney injury. So if you take a few extra steps and slow down the procedure a bit and just give some fluid in the pre-procedure room, have a patient checking out, maybe send a nurse out to the house to check a creatinine afterwards. I've never had a patient complain. It's safety first, and we always win with that.
Absolutely. Emmanouil?
I think 4 things. One is find the patients at risk, diabetes, renal failure. Hydrate them, limit the contrast volume, use smaller contrast agents. These are things we can do, and they can minimize the risk of CI, AKI.
Absolutely. Put the patient at the center of all we do, and we won't go far wrong. So once again, thank you very much. And to everyone, to our speakers and to our audience, stay safe, stay well, stay curious. Bye for now.